Okay, we can get started. Welcome, everyone. I'm Swati Pradhanbhat, Director of Global Scientific Affairs at Abbott Point of Care, and it is my absolute pleasure to introduce our speaker today, Professor Louise Cullen. Dr. Cullen is a preeminent staff specialist in the emergency medicine in Brisbane and a professor at the University of Queensland. Professor Cullen is internationally recognized as a leading clinical trialist and outcomes researcher in acute diseases, particularly in the diagnosis and management of patients with acute coronary syndromes. Professor Cullen has authored over 350 peer-reviewed publications, including landmark studies published in the New England Journal of Medicine and The Lancet. Her research has directly influenced national and international guidelines, including the 2016 Australian ACS guidelines, the 2020 ESC guidelines, the 2021 ACC-AHA guidelines. She has led transformative initiatives such as the Accelerated Chest Pain Risk Evaluation, or the ACRE project, which reshaped emergency care models across Queensland. Today, Professor Cullen will share her insights on high-sensitivity troponin testing and the evolution of accelerated diagnostic pathways. She will explore how these innovations enhance patient safety, reduce ED congestion, and improve resource utilization. We'll also hear about the emergent role of point-of-care testing in enabling faster, more confident clinical decision-making. This session will run for approximately 45 minutes, followed by a Q&A. However, please feel free to submit your questions in the chat at any time, and we'll address them during the Q&A session. Please note that we will be recording this session and which will be available on demand at a later date. So without further ado, please join me in welcoming Professor Louise Cullen.
Thank you, Swati, for the introduction, and thank you everyone for having me here today with you. This is an area of interest, and that is high sensitivity point-of-care troponins of mine, and a really exciting time, I think, to be in this space for now and for emergency medicine in particular. I am an emergency physician, and I do realise that we're going to have potentially cardiologists, primary care physicians, as well as our lab experts online. So please let me know and write something in the chat or question if I say anything that doesn't make any sense to you. This session is being sponsored by Abbott. However, my views are the ones that are in this. Now, a couple of the different roles that I hold. I am a member of the IFCC, which is the International Federation of Clinical Chemistry, Cardiac Biomarker Education Committee, and also part of the ESC, Acute Cardiovascular Care Biomarker Committee as well. What we're going to run through this evening for you, this morning for me, is a couple of things. And first and foremost, what we want to do is talk about risk assessment strategies for patients with suspected acute coronary syndrome in the ED and what they look like. We'll talk a lot about the relatively new devices that are available, which is allowing us to do point-of-care troponin testing. I'll talk to you about the benefits of both lab-based and point-of-care assays in terms of the high sensitivity versus our contemporary assays, and also then look at what is required for successful implementation of point-of-care. Now, interestingly, when I was doing this, I am fortunate to be able to talk in a number of different places around the world. And when I looked at the Canadian statistics and compared them to my own here in Australia, we are actually very similar. We are very large countries with diffuse population across a broad area. The Canadian statistics are that you've got 16 million ED presentations per year, which is a little bit less than the Australian 24 million. But your growth rate of about 3.5% to 4% is actually very similar. So in the latest information, I was able to find about 1 million patients are presenting annually with chest pain. And unfortunately, you've got the same problems that we do here, which is that admitted patients wait a very long time in our EDs before we can access our beds within the hospital setting. So with yours, about half move in about 14 hours. And what this all leads to for us is the problem of ED overcrowding. And as I said, it is not unique to Canada or Australia. This is something that is occurring globally in the US and in European countries as well. The impact of this, though, is significant. There's incontrovertible evidence that ED overcrowding leads to patient harm. We have patients that do not wait and leave before they're actually seen. If they are admitted to hospital, we know that they have a longer inpatient stay, and it actually increases their cost of that episode of care. From the staff perspective, there's a lot of staff burnout in the ED space, violence, and we know that we're inefficient when we're working in that overcrowded space. But I think the most important thing for me is the patient morbidity and mortality that is directly associated with ED overcrowding. Now, you may wonder why I actually start with ED overcrowding when we're going to be talking about troponin, and that's because patients with chest pain and suspected acute coronary syndrome are one of the largest groups of patients that come to our ED, and therefore they impact our whole department. It is the first or the second most common cause of people coming to adult EDs within the Western civilization. And we know that the vast majority don't have an acute coronary syndrome nor any other serious disease like aortic dissection or pulmonary embolism after we undergo the assessment. And so what we're trying to do is identify which patients, therefore, from an ED perspective, that we're actually able to get home and discharge from hospital, in a reasonable amount of time to declog our emergency departments. Now, just a little tiny thing, just a reminder about how we diagnose acute myocardial infarction, because I am going to be focusing a lot about troponin, but it is not about troponin at all, not alone. It is a combination of our clinical findings, ECG findings, along with troponin evidence of an elevated troponin that shows us that someone's got myocardial injury, and the synthesis of these things, sometimes with additional tests that we need to do, identify those people who've got an acute myocardial infarction, and that's in accordance with the fourth universal definition of myocardial infarction, and the fifth one is due out next year, and I'm sure it will be very similar. So now let's segue into what I was going to talk about first off, and that's about rapid and safe risk assessment strategies. And I am going to be talking a lot about risk stratification rather than diagnosis. What we do in the ED is a lot of risk stratification, and there is a subtle difference. We are looking towards the likelihood of a problem or a probability versus the presence or absence of a specific disease per se. It does mean that you'll see me talking more about low risk, but you may have heard and read in the literature about the rule out AMI pathways. It's a similar sort of thing that I'll be referring to, but I actually think nothing's ever 100% in medicine, so I do talk about low risk rather than rule out. Equally important, I'll be talking about high-risk patients for acute myocardial infarction from an ED perspective rather than rule in that, again, is in the literature. So there are a number of different ED strategies. I'm very much going to focus on the robust protocols that have been based predominantly on ECGs and high-sensitivity troponin assays. And the first one I will talk about just in reference is the high-stakes pathway, which has been tested and validated on numerous assays. With all of these strategies, the first thing, of course, is identifying those people who've got ST segment changes on our ECG or other findings of occlusive myocardial infarction. And those people are never put down any of these assessment pathways because they need urgent reperfusion. But we have the vast majority of people, more than 95% of people that tend to present to the EDs don't have those sort of ECG findings. And therefore, we are then trying to work out whether or not they could have an acute coronary syndrome or acute myocardial infarction as their cause of chest pain and presentation to the ED. Now, this strategy, like others that I'll be showing you, have got sort of a three-tiered system with a single troponin being taken initially, which in this case with the troponin I assays is less than 5 nanograms per litre, that identifies a low-risk cohort with just that first assay. Equally important in this one, if you've got an elevated value above the sex-specific 99th percentile, you are deemed to be high risk. And for everybody else, they do repeat testing at 3 hours with then subsequent change in values, so 3 greater than or equal to 3 or less than 3, putting you into the two different boxes of low risk and high risk. But what you end up seeing is after that period of time, more than 3/4 of our patients from an ED perspective potentially are low risk and able to be discharged and managed out of the acute hospital setting. The other strategy that I think is very well known around the world is the ESC, or European Society of Cardiology, 0-1 and 0-2 hour strategies. And these are actually very, very similar in that you remove the patients that have got ECG changes that are consistent with acute myocardial infarction. And then either over 0 and 1 hour or 0 and 2 hours, we take blood tests, sift and sort these people into the so-called rule out or rule in or an observational pathway. Within this pathway also, we have the very first value, which may allow us to identify some patients as being low risk and some patients as high risk, and others, of course, then go on to have serial testing over 0 and 2 hours. Now, with the ESC strategy, unlike the high stakes, it's very important to recognise that there are assay-specific metrics that we need to be using. So it's incredibly important that you know what assays that you're using in your own local environment and apply those numbers within the setting appropriately. What is interesting to know, and what often comes up as a question, is can we really use just single troponin testing to discharge patients? And I can tell you locally, we've been doing it for a number of years. This is a paper that came out very recently in Heart. And this is sort of in addition to all of the evidence that has built the ESC guidelines, but it shows you that for standard care, which was a 0 and 3 hour strategy in this particular paper, using the 99th percentile, when you used a 0 hour value less than 5 nanograms per litre that you'll see in the high stakes and in many of the ESC guidelines, these patients were deemed to be low risk at a very, after up to 1 year. So operationalizing the ESC guidelines in particular, and really any of these strategies that are going to take serial samples, it's important to think about how we're going to be doing that. So patients come in and first of all, we look at their ECGs. That very much is the first test that patients need. But what we realise is that most patients need to go on and have blood sampling, which we call the 0 hour sample. And from that, we then go and determine whether or not the patients may be low risk, high risk, or need further testing. And what, of course, you'll note or understand for those of you that are utilising lab-based assays at the moment is we aim for a turnaround time of 1 hour. And I do find that many places, the majority of them around the world, fail to get all results back within an hour. Now, if you're utilising a 0 and 1 hour strategy, it means that you'll often have to take that second sample before you've actually got the results of the first sample, and you may not have actually needed that test to be done at all. And so that's one of the things I think that's been hampering this approach of a 0 and 1 hour strategy, because we haven't been able to operationalise it well in clinical care. Moving now on to troponin assays, because we need to do a bit of a dive to work out which ones can and cannot be used in these sorts of strategies. And now many of you will be familiar with the criteria set out by the IFCC and supported by others about what makes a high sensitivity assay. And that is that there's two key criteria. One is that the coefficient of variation at the 99th percentile is less than or equal to 10%. And the other thing is the ability to measure concentrations that are above the limit of detection, the LOD, but below the 99th percentile in more than 50% of healthy men and women. We also know now that, when we initially changed to high sensitivity troponin assays, there were some questions and queries about the validity and the and value that we would find from them. We know clearly that they allow us earlier and more accurate diagnosis of patients with acute myocardial infarction. We have great studies now that have been able to show us that in health systems that are using them, unlike others, they have lower 1 year mortality. They are very efficient for risk stratification, which of course has got advantages for our healthcare systems. Single blood draws and reduced timing for serial blood draws ultimately ends up giving us back time and decreasing ED length of stay. There's patient benefits too, which we need to acknowledge, and that is that they reduce their anxiety, they get the information sooner, and earlier discharge for anyone, not just ourselves, but the patients in particular, is always appreciated. The thing that we have also seen, in the context, particularly just at the moment with the introduction of sex-specific cut points, is that we're beginning to get into that stage of personalising medicine towards the people and the information that we've got and work out what is right for an individual person. And I do predict that with time, we're going to see these machine learning and other AI-assisted technologies to help us with our risk stratification of people. And interestingly, they're also cost effective. Although there's a higher upfront test cost, the earlier discharge combined with what we've been able to show, which is reduced downstream healthcare utilisation, ultimately means that these are a cost-effective strategy. Okay, now let's talk more specifically about the new kid on the block, and that's, the high-sense troponin point-of-care assays. And that's quite amazing to think that we can take that technology, from the lab, and it's not the same technology, but that sort of expertise, and put it into very small devices near patient care. And please forgive me from those of you who are from the lab. This is a very simple schematic diagram from an ED perspective of what happens when blood gets taken. We take it here in the ED, we send it off to the lab. Now, an important step in it, of course, is the centrifuge. The tests are done and then uploaded into our LIS, or our lab information systems, where they then become available for us to see. Now, as I said, ultimately, we're aiming for this to be about 1 hour, but what that realistically means is that I've gone and seen 3 or 4 other patients in that period of time. And when I get those results, I have to recognise those results are available, but then also reframe my thinking back to that particular patient and apply that information that I've got from them back to, back into that patient's care. And the beauty and the attractiveness of point of care is, of course, is because that within a rapid period of time through our assessment processes, we may actually then have those blood test results available when you see the patient, that allows you to make decisions, informed decisions at that point in time, and ultimately allow us to support that patient's care at a much earlier time. Now, there's a number of point of care devices, and not all of them are exactly the same. I think when I think about point of care, I think about something I can hold in my hand, but there are some benchtop platforms and portable handheld platforms as well. And there's 3 currently on the market: the Triage True, the iStat Alinity, and the Italica VTLI. And interestingly, the 2023 European guidelines actually have got the metrics for 2 of the point of care devices already in there. And I'm absolutely sure that with time, that's going to just broaden. There's a few clinical studies, and forgive me, this has got 7, but literally this week an 8th was published, that have looked about the diagnostic accuracy of point of care high-sense troponin assays from an ED perspective for the diagnosis of acute myocardial infarction. I've been very fortunate, and I've been involved in 4 of these 7. Actually, it's now 4 of the 8, as I said, and I'll talk to the 8th one later on. What you can see are that there are different assays, there have been some different study types, and importantly, some different sample types that have been investigated and reported in these. But it is a moving feast of information, which is exciting, because we are seeing the clinically relevant information now be available in publications. I'll start with one of the early ones, and that's the Triage True, that was published by Christian Mueller and Jasper Boddinghaus in JACC in 2020. And that was to compare the point of care Triage True versus 2 very well recognised and highly respected assays, and that's the Roche TNT and the Abbott Architect TNI assays. They then also wanted to see whether or not they could derive a strategy that could be used in clinical care for serial sampling over 0 and 1 hour. First and foremost, they found that the diagnostic accuracy was very high, and it was comparable to that of the 2 lab-based assays. So this was really some of the early information that we could get to say that this was of clinical interest. They then went on to look at just the single sample only and defined a value of less than 3 nanograms per litre at that first blood draw as valuable in identifying patients who are at low risk. And when I say valuable, this cohort of patients had a sensitivity and negative predictive value of 100%. So no patients who with a non-ST segment elevation myocardial infarction was missed. And again, all of these studies have taken out people with significant ECG changes. They also found a direct rule-in value of more than 60 that allowed 10% of the patients to be identified with just 1 sample. So more than 50% of the ED population with the first 0-hour result that was available within minutes were able to be sifted and sorted into, could we potentially send this person home, or do they need to be admitted? So then they went and built upon this to look at what was a 1 hour value and a change metric, or the delta that we talk about, that would help sift more of the population. Essentially, this is the strategy that they came up with. And after that 0 and 1 hour testing strategy, there was only 3 out of 4 patients could be identified as high or low risk, with only a quarter of the patients that needed further testing and further evaluation. And that's incredible by comparison to what many places have been doing up until now, which was at least a 0 and 3 hour strategy, if not 0 and 6. Now, this is one of the many papers where they have gone and Christian Mueller and his team have gone and followed up people over years and looked at cumulative sort of event rates for major adverse cardiac events for the patients. And what you can see is the green bar here is the low risk proportion. And it is out to the 2-year mark, 1.6%. This really further underscores the safety of these early discharges from the ED for most patients, with further outpatient management being absolutely clinically appropriate if required. So then I was fortunate to work with Fred Apple, and we looked at the Siemens Atelica VTLI point of care assay. And again, we wanted to look at a threshold for 0 hour, which might give us the safe identification of patients who are low risk. And we aimed for a negative predictive value of more than 99.5% and a sensitivity of more than 99% for an acute myocardial infarction. And in the SIEGE, which is a US cohort, and the SAMI, which is an Australian cohort, we did look at some different sort of samples, whole blood versus plasma, but we're able to identify, derive, and then validate the figure of less than 4 nanograms per litre that provided us, again, that information about the cohort of patients coming in that were deemed to be low risk with very high confidence. We and others always show, though, these bar graphs and all of the statistics that we possibly can to help provide people with the information that they might require. And you can see that there are differences in the sensitivity, in the greyish sort of bars up top versus the negative predictive value, and the proportions of patients ruled out at each time point as well. That allows us to then define which is the value that we would actually then recommend, which meets the criteria that we set out for safety for rule out. We did go on, though, and develop a 0 and 2 hour strategy in the same cohorts using that same assay as well. And again, it looks an awful lot like what I've shown you before, which is in the ESC and Christian Mueller's work, which is a low risk, high risk, and an intermediate risk cohort. And again, in the derivation and validation, we were able to find significant proportions of patients that were able to be identified that we could safely move from the ED as well as move in. So somewhere between 50 and 60% of patients were identified as low risk. Now, the new kid on the block, and one of the exciting reasons why I'm talking to you today, is about the Abbott iStat. And I do know that in Canada, both the iStat 1 and the iStat Alinity have been launched in your spring, which is my autumn. So they're fairly new for you in terms of that high-sense assays. I was, again, very fortunate to do one of the early publications or look at this assay. And I was able to work with my team to look at a 0 hour threshold to identify patients that were low risk. We used our biobank in the SAMI trial, and in our cohort, about 5.5% of patients have got an index MI. And the data, that we presented in this way is interesting in the sense that we actually decided to present, of the 1,000 patients, we decided to present both the values that, as in the concentrations of troponin, that would give us both a high sensitivity and a high negative predictive value, and there is some differences. Now, negative predictive value, and I'll talk to this in a little bit, is influenced by the prevalence of disease. So if you used a cutoff of this assay of less than 8, it achieved a negative predictive value of greater than 99.5%, but the sensitivity fell away. Whereas a cutoff of less than 5 nanograms per litre allows us both 100% sensitivity and very high negative predictive value at the same time. So this was an early look into this assay, which gave us some signal that this was going to be of some clinical use. Now, what is most exciting, and I'm sorry I haven't got it actually here just at the moment, but this week a paper has been published by Alan Wu in the Journal of Applied Medicine and Clinical JALM, Lab Medicine, which has gone and used all of the pivotal trial study from Abbott with the whole blood in over 3,500 patients. They have gone and confirmed within this paper that a value of less than 5 nanograms per litre achieved high sensitivity and high negative predictive value in a completely independent, very, very large trial. So please look for that. It was just a little bit too quick for me to get it uploaded into my slides. I'm sorry. So again, just a little tiny segue into why the different values. And with sensitivity, we are very much influenced by how many patients have got acute myocardial infarction. So example, if you miss one patient out of 50 patients who have a myocardial infarction, your sensitivity will dramatically drop relatively quickly, will be low. Whereas with a negative predictive value, if we've got 900 patients, who don't have it, and we've got one person that's a false negative, it then becomes something like 900 over 901. And so negative predictive value alone, I don't think is the right metric to show you. But again, within the paper that we just published, we showed the same thing about the troponin value here of less than 5, allowing us more than 50% of our patients to be identified as low risk, with both very high sensitivity in the grey bars and very high negative predictive value in the blue bars at the very top there. As I said, I would go back to that Journal of Applied Laboratory Medicine article with Alan Wu that's online now, because I think this is the next step and the next in the story of this particular assay. Just one thing to think about in terms of low risk, they all seem to be fairly comparable. We're talking about of the order of 40 to 50% of our patients with a single value to be where we can exclude that patient as having an acute myocardial infarction. And again, from an ED perspective, this is what I look to for decongesting or decongesting my emergency department. So half of our patients, 50% being low risk, is incredibly valuable. And that's where I think, honestly, the point of care platforms are most valuable. So one of the things that we need to think about, though, is this is an emerging story. The sample type is important. As I've said to you, we've gone through different studies that have looked at whole blood versus those that have looked at plasma, and the whole blood studies are now available. The next stage is looking at our use of it with our intended users, the ED physicians and ED clinicians, and real world experience is very much wanting to be known. Well, I'm going to talk to some of this because we do know some things, which is really exciting. As I said to you before, the implementation of high-sense assays was met with concerns, and I am hearing similar concerns about, the implementation of point-of-care assays. What I do need to reiterate, though, is that we've got enough information now currently, and we very soon will have with regards to, on lab-based assays, and very soon we'll have that same sort of information on point-of-care assays that show us that any initial challenges that we might actually have in implementing point-of-care high-sense assays have really been worth it. And I do believe that the point-of-care high-sense assay information that's coming up from some large studies is also going to be quite convincing about the need for change and the benefit for change. Now, this particular study that I was involved in was a large study that I think really for me was the final sort of, naysayer for people that were naysaying about high-sense assays. This was the study that I think really hit it on the head. And what we did here is we looked at the cost effectiveness Australia-wide about the transition from a conventional to a high-sense assay. These were lab-based assays rather than the point-of-care assays, though I must say. What we did is we took 9 large tertiary hospitals across Australia. 2 of them did not change to the high-sense assays during the period of the study. 7 of them did. And we looked at all patients coming through with suspected acute coronary syndrome. We took 12 months of data before and after implementation, which led us with cohorts of 87,000 before and 93,000 patients after. And what we found was there was a reduction in the cost of that first event when they came to the emergency department. So the Canadian dollars almost 1 for 1. So that's about 1,000 Canadian dollars. We also found that with the decreased utilisation of other services and even re-attendance to the hospital, we found that there was a reduction in total costs of over $1,300 in 12 months. But most importantly to me is that when we introduce the high-sense assays across Australia, we introduce sex-specific cut points. Not only do the high-sense assays give us the benefit of reducing patients who being able to help sift and sort and identify those patients who have a major adverse cardiac event, and those centres that were using the high-sense assays had an overall reduction in MACE of 0.5%. This was much more significant in our female population, who we know for a number of reasons there's a bias against the recognition for female patients who've got heart attacks. And so we're actually able to reduce the MACE rates in our females by over 1% in sites that were actually using it. Now, when I was talking about the question was related, sorry, I just saw the question about, are these dollar values per person? Yes, they're per person, they're per patient. Sorry, I just thought I'd flick to that for just 1 second because it is per patient. When I talk about implementation, this is the study to look out for. Now, I'm going to be talking to you about the published paper, which is this one, a preliminary results. But on Sunday at the American Heart Association annual scientific meeting in New Orleans, Martin Than will be presenting the whole data set, which is more than 60,000 presentations for this study called iCare Faster that occurred in 6 sites across New Zealand. So I can't release the full results just yet, but I know that they will be available very, very soon. I'm going to talk about iCare Faster now, though, and the preliminary information, which was a implementation study in New Zealand. And this is the information that we've got from the first site where it was implemented, which is the Christchurch ED. And what they did here is they looked at all patients with suspected acute coronary syndrome who had troponin testing. Everybody then went through to have troponin via point of care. It was the Siemens VTLI, but I'd argue probably it's with any of the point of care platforms that this same effect will be found. And for all patients, not just the low risk patients, there was a mean reduction in their ED length of stay of 32 minutes. Now, I know that doesn't sound a lot, half an hour, but from an ED perspective, that is half an hour more that I have got to actually be able to see somebody else in my department. So it's a release capacity of 30 minutes. And when you looked even just in one day, it was 21 fewer patient hours of contact each day, or, well, that particular patient, or over the 8-week period that is being shown here, over 1,000 hours that's actually being released. This sort of initiative creates capacity for us to see the ever-increasing numbers of people that are sitting in our waiting rooms needing to be seen. And we don't have many things that I can think of, recently in emergency care, and when I say recently, I mean over the last few decades, that actually give us back this same sort of capacity to see more people. What it means, though, if you're working in a big hospital that sees about 100,000 patients per year, and you see about 8% of your people with suspected acute coronary syndrome, this actually gives you a saving of nearly 180 days per year, which is incredible. We're not building hospitals at the rate that we need. And so these sorts of initiatives are incredibly important for us. Now, there are some important things to think about implementation, because as I said, I think change is not necessarily straightforward. And I think this is one that we need to do with our eyes wide open about all the challenges and start from the right place. You need 3 things. You cannot think about implementing point of care high-sense troponin without lab expertise and support. There also needs to be the clinical expertise in championing of this initiative as well. And I do think you need someone or a small team of people that can help manage the project management of this. But ultimately, we also need to have our executive leadership underpinning all of this. Change can take time and can take some encouragement and support and financial support, and we need executive to understand the why. The why, as I said, is what I've just shown at the very beginning. We're doing this because overcrowding in emergency departments is bad. Point of care troponins are the technology that is in reach at the moment that has what I believe to be the most significant impact on changing the way that we provide care to actually give us back some capacity in our EDs. So what we're not trying to do, it's important, we're not trying to take away the lab-based assays. This is a complementary tool, and I do believe that in major centres, the lab-based assay will always be used for inpatient teams. It's very much an ED or front of house. We'll talk a little bit about places like urgent care centres and primary care as well, but it allows us to do faster assessment of patients with suspected acute coronary syndrome. And of course, that leads to improved patient flow and increased safety. The stakeholders in the hospital setting, which is different to urgent care and others, are the ED clinicians and nurses, particularly the people that we think might be running these tests. We need our pathology team, and our point of care coordinators are integral to that. Our inpatient teams need to come along and understand this, because this will have implications for them, and I'll talk about it in a moment. But also we need to have expertise from IT, clinical governance and administration at the same time. Now, with pathology considerations, forgive me, as you all know, I'm an emergency physician, not a pathologist. I've been fortunate to work with some incredible pathologists over my lifetime, including people like Fred Apple, who have guided me with some of the requirements for what is needed from a lab-based perspective. And this is just touching the surface, but there is everything from the IT and the middleware and the connectivity, firewalls, for example. There are equipment issues, there are reagent issues, there's quality controlled materials that are required in the procurement of those, as well as the cartridges. There's a lot of different documentation, both internally within the lab, but also that's got to be clinician facing as well, that's required. And we do need to train a whole new workforce or create extra skills in a workforce to be able to use these. Within the Australian context, all of our testing is accredited by NATA, and so your local and regional accreditation needs to be considered as well. And even down to things like, do we have lockout systems for people that haven't done all of the training? Do we have barcode scanners to make it easy? All these things need to be considered. From a clinician-focused perspective, we need clear instructions for use, and we need to understand the reporting. Now, high-sense assays, of course, are reported with nanograms per litre. There are different reportable values that would need to be agreed upon, and I know within the US, for example, they report to the LOQ, whereas many others are reporting down to the LOD. As I said, sex-specific cut points, I think, are just a given in this space, but you will we all will come across issues where we've got both point of care and lab-based assays within the same healthcare system. We need to make sure that the point of care assays are clearly identifiable. From the ED workflow, of course, we really want to be focusing point of care technology with our suspected ACS pathways. I know that there's been a creep of troponin coming to other places, but still the greatest utility, the place where it's actually making a difference in terms of changing patients' management, is in acute coronary syndrome. The timing of the strategy needs to be considered. Now, I do think if we're going to make a change to point of care, we need to do the right change first, which is 0 and 1 hour rather than 0 and 2 hour algorithms. But there may be different systems issues as to why places would prefer a 0 and 2 hour strategy. The device, of course, we need to think about the space where it's going to be, the training that needs to be done, and how we're going to handle all of the values like we do at the moment with our lab-based assay results. The inpatient team coordination and even the ED coordination is not insignificant. We have been told for decades, appropriately, for many devices, that the lab is superior, the lab results are superior to point of care results. And look, that had been true with troponin until now. And I think I've shown you enough of the evidence to show you that analytically, these point of care platforms are equivalent to our lab-based assays. For those patients that need to come into hospital, though, that need further evaluation, so the high-risk people, there, of course, will be the tension between lab and point-of-care assays and whether or not we can do serial testing utilising two different platforms. And we know we can't. So we need to think about and have strategies about what are we going to do about patients that need to be admitted. And so there are suggestions, for example, like redrawing the baseline test for those people that are being admitted so that all serial tests can be compared against the same assay, which is absolutely critical so clinical mistakes don't happen. The most important thing, I think, though, is having the vision about where we need to go and why we need to be doing this, and keep circling back to this. Whenever we come across a challenge, we need to be working out how we make things work, because we are under the pump on our knees in many EDs, and we need strategies to be able to maintain high quality emergency care for our communities. So look, fast forwarding, and really this is a rapidly evolving space. We have opportunities, and there are some very big international studies happening at the moment in the pre-hospital ambulance service, looking at, do we use point of care in the ambulance, not only if it's elevated to go and take you to the right place the first time, so take you to cardiology and PCI capable hospitals, but also in the primary care setting. To, you know, we have our primary care expertise in ECG interpretation already. What they're lacking at the moment is rapidly available information on troponin, and there is no reason why these assays should not be used. So there's a big study happening at the moment in Norway that I'd argue is going to be a landmark paper, and I'm hoping it'll be finalised by next year. If not, it'll be early 2027. That will be showing us the benefit of point of care high-sense troponin in primary care settings. But it also opens up specialist rooms and outpatient opportunities as well to be using this as well. And in some of our outreach services, for example, into aged care facilities, and trying to identify which patients do need to come to the hospital or not. So look, I think that, you know, point of care high-sense assays using troponin assays are actually ready now for clinical use. We know that the time for diagnosis and discharge can be reduced, and rapidly we are exploring non-hospital based testing and assessment for patients with acute coronary syndrome, where I see there's going to be huge advantages down the long run for everyone. Not just ourselves as clinicians, but our hospital services, and equally important for our patients as well. And particularly, I should say, in our rural and regional areas, like Canada, Australia is a huge country, and we have the need to provide optimum care for patients no matter where they're located, without having to transport them to major centres. This has been a whirlwind run through a whole lot of information. I'll just direct you to one article that we recently released from the acute cardiovascular care group from the ESC, and we summarised sort of the literature that was available up until that point in time when it came out this year. And as I said, there's more information that's there that might be of interest to you as well. So look, thank you very much. I think the most interesting time sometimes comes from the questions that come up, so I'm very happy to take questions. I appreciate your time this evening.
Thank you, Dr. Cullen. That was great. So we'll get started with the questions. So the first one, what are some of the challenges clinicians face when trying to implement point-of-care high-sense troponin testing into existing lab workflows?
Yeah, I think that is a very interesting question. I honestly think we need to have more of these shared discussions amongst clinicians and pathologists and executive and others, to just realise just how challenging things are at the moment, and how, in terms of ED overcrowding and the demands on ED, I think if this is out of sight, out of mind, people don't appreciate why this is such a big thing. And it seems really funny that the ED folk are jumping into sort of testing, troponin testing, troponin assays and things like that. But it really has come from an area of great need. We need to do something. And I think we need to have that shared and common understanding first and foremost. When we are all agreed on this and we all push in the same direction, I don't think it's difficult. But I think we need to understand what we're trying, why we're doing this, and what we're trying to achieve from this. And that is, you know, release capacity for us to care for the ever increasing numbers of people that come to our emergency departments and still provide excellent care.
Thank you. Second one, how does one deal with testing results that don't precisely follow the 1 hour, 2 hour, or 3 hour cutoffs quoted in the guidelines?
Yeah. So what you find is that those ones that fall between become into that observation zone. And honestly, the guidance about that differs about what people do. So for example, in the ESC guidelines, you'll see reference to doing an echo or a third test. Now, in my institution, in many places around Australia, to get an ED echo is nearly impossible. We just don't have that sort of capability. So people are doing third testing at that point in time, or doing other investigations, for example, coronary CT scanning or some sort of provocative testing. But it's not well described yet in the literature. I think there's a very regional heterogeneous sort of approach to this. And I know from my thinking, what we need to do for that 25%, and it seems to be consistently about 1 in 4 patients fall into this intermediate zone where they don't clearly fit one or the other. We need to do another test. And so we're looking very much at CTCA in the Australian context to help define those people's risks of coronary artery disease and potentially, acute myocardial infarction.
Great. Can you talk a little bit about the limitations of applying fixed cutoff values across diverse patient populations, and how might sex-specific thresholds help clinicians?
Yeah, so sex-specific at the 99th percentile absolutely is of value. So when you look at the high-stakes pathway and the 99th percentile, very much I advocate that the advantage of having that. So, and look, I'll just rewind a little bit. The diagnosis of myocardial infarction or myocardial injury requires a value greater than the 99th percentile. So what has been happening when we've used overall cut points, we know that with high sense assays, women have got a lower 99th percentile. What is normal for women is actually lower than what is normal for men. But we've been using overall cut points, which sort of pushes up the value to a slightly higher than women and slightly lower than male cut point if you use that. That means that I've got to have more myocardial injury before it's recognized than a man. So the idea of using sex-specific cut points takes away that bias in that, but that's for the diagnosis, not for the risk stratification. When it's been looked at for risk stratification using these very, very low values for rule out, we haven't found that there is a need for sex-specific cut points down at that low level. And Nick Mills and his colleagues in Scotland have done some eloquent studies looking at this that just show that when we're talking of values of 5 nanograms per litre, that having a sex-specific difference down at that level is not advantageous. It doesn't improve safety, and it doesn't improve proportions of patients who can be ruled in or not ruled in or ruled out at that point in time.
The next one, what is the typical time for a point-of-care test, troponin test to be run? I believe our lab analyzers need about 20 minutes of runtime.
Yeah, so that's interesting, isn't it? Because the runtime's probably not dissimilar. The big thing is the centrifuge, the transport, and all of those other elements from there. So, of the order of 10 to 20 minutes is where most of the point-of-care assays are sitting at the moment. Yeah, so that's... And we've done huge work locally and others about trying to reduce all of that other time, that's either side of the centrifuge and the actual testing time, accelerated express lamps and tube delivery systems, having dedicated systems that are ED only, which have got bells ringing when they get to the lab so that they're aware that there are lab-based things. Many of us have tried to hone and refine that element to take out that. But it's still a fixed time point. We are still struggling to get results within 60 minutes.
Right. And the last one that I see here is, do you think these fast troponin tests could help hospitals in rural or underserved areas give better care?
Oh, most definitely. And equity of healthcare is something that I within the Australian context, I sort of resonate with. At the moment, we are doing our best with contemporary assays that may be available, but the strategies that are being utilised are quite different to where we've got high sense assays. We need to, wherever we can, set the bar at the same level for everybody. And the variety, rural and regional areas, yes, but even I would argue, when we look at our elderly patients who are in nursing homes and things like that, we are trying to manage patients in their place, the place that is best for them, which may not be in the hospital sort of setting, but we do need some informed way to identify which patients may not need, urgent transfer, whether it be by retrieval services and helicopters and planes from regional areas, or even just ambulances transporting them from nursing homes into the hospital sort of setting. That anytime that we can do this better, but accurately and safely, that's a huge plus for us.
Great. One more just came in. Clarification on the timing of result question. How do we deal with the results that are outside of the 1, 2, or 3 hour timing?
Yeah, this is also a good thing, because although you see the studies saying 0 and 1 or 0 and 2 or 0 and 3, if you actually delve into the methodology of these trials, A 1 hour sample is often anywhere from 45 minutes to 1.5 hours. A 2 hour sample is anywhere from 1.5 hours to 2.5 hours. So one of the things to look at in the literature is really, how tight these sample testing is actually being taken, because I'd argue we're so busy in the ED, it is never bang on 60 minutes or 120 minutes. It's just not that. So there is a bit of allowable or acceptable variance in when they're being taken. I'm not saying taking a 6 hour sample. I'm more concerned though if you take them early rather than if you take them late. If you're taking a 0 and 20 minute sample rather than 0 and 60 minute, then I might be concerned, because essentially what I'm looking for is that time that it might take to change if someone's got acute myocardial injury and detected in the circulation. So later for me, I'm less concerned about, but are there parameters around it? Well, yes, generally. I also, when we are working under systems and pathways where we are, for example, using a 0 and 1 hour strategy or 0 and 2 hour, our nursing staff are incredibly motivated to try and get these patients assessed as efficiently as they possibly can do. And they often are on the money to try and get that sample done so that they can, care for that patient, act on those results. And so I find that their support in terms of time is invaluable, but it's never exactly 60 minutes or 120 minutes. Yeah.
Great. I believe that is it that we have for questions. Maybe we'll just give another minute in case anyone has a last call.
Of course. And really, for a Friday afternoon, for people to give up their time, I do appreciate it. It's a big ask.
Absolutely. Well, thank you so much, everyone. I think we will close today. This was an absolutely insightful presentation. Thank you so much, Professor Louise Cullen, for taking the time. And thank you, everyone, for attending and listening today.
Thank you, Swati, for having me. And look, if there's anyone online that wants to reach out for me, please do find me, and I'll respond to any of your questions. Thank you, Swati.
Thank you.